This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about whether NATO is ready for conflict with Tim Hodgetts. So what we want to do is really delve into NATO's medical readiness for large-scale conflicts, addressing the pressing question about preparedness and challenges in the face of hybrid and cyber threats. We're also going to ask how NATO adapts its strategies to meet these complex needs for contemporary warfare. So we're also going to address some of the lessons from recent conflict, that of Ukraine, Afghanistan and Iraq conflict, and how these experiences have shaped NATO's unified approach to combat medicine. So from mass casualty management to the integration of cutting-edge innovation like telemedicine, robotics and AI, we discuss the systems and technologies that underpin NATO's ability to respond effectively. So the importance of collaboration and interoperability takes centre stage as we explore how NATO trains medics and aligns medical equipment across diverse member nations. So additionally, we're going to examine how NATO balances military medical readiness with supporting civilian populations in conflict zones, leveraging partnerships with civilian healthcare systems to enhance preparedness. So finally, we're going to tackle some ethical and humanitarian considerations and shed light on the psychological resilience, mental health of medical teams, and the challenges of providing care to allies and adversaries. So to do this, I have Tim Hodgetts with me. Tim has been on the podcast with me before. He was recently the serving Surgeon General of the United Kingdom Armed Forces, also the Master General of the Army Medical Services, and the elect chair of the Committee of Chiefs of Military Medical Services in NATO. His clinical background is as a professor of emergency medicine amongst many other hats. Welcome to the podcast, Tim.
Thank you very much.
So I wonder if we could just dive in and just really get your perspective initially on how prepared NATO is medically for large-scale conflict, and indeed, what are some of the key challenges?
So we are diving in right at the deep end from the outset. And I think to understand NATO's medical readiness for large-scale combat operations, we have to reflect a little first on the geopolitical context of the last 30 years. So when the Berlin Wall came down and the Cold War ended in 1989, we entered a period of peace in Europe. And the threat since then of large-scale conflict has been low. And linked to this has been a progressive reduction in the size of our standing armies, and our involvement in only small or medium scale, relatively low intensity asymmetric conflicts in that intervening period, I think has only served to reinforce the need for smaller professional armed forces. So in parallel, our military medical services have also contracted in size. But we did develop exquisite capabilities to transform the survival of small numbers of seriously injured. So with Russia's illegal invasion of Ukraine in February 2022, we've now re-experienced peer-on-peer conflict at scale. And we're having to relearn the lessons of attritional trench warfare, relearn the challenges of moving and treating high volume of casualties. And we've had to recognise that while we have very effective clinical capabilities, we must also create the capacity that we would need in war. And importantly, I would observe that the principal effect within NATO has been to energise our medical preparedness. And this has been led by the Committee of Chiefs of Military Medical Services, or COMEDS for short, which I've been privileged to chair. And we've re-evaluated our effectiveness to treat and move large numbers of sick and injured across and between continents. And we've pressure tested our effectiveness within command post and field exercises. Most recently, the very impressive Vigorous Warrior exercise that was held in Hungary last year. But we do know the clock is ticking on our readiness for war. And I believe we have exploited the available time to prepare. And as the saying goes, never waste the opportunity of a good crisis.
Indeed, indeed. And you make a number of very good points there. I think pressure testing as an analog of preparedness to start to leverage and understand the gaps and some of the rate limiting steps is absolutely essential. Tim, we are living in this now, as I'm currently living in Germany and see this from a unique standpoint in Germany, whereby there is this almost semblance of hybrid warfare now, and also cyber threats, which some of which go under my radar and I don't really detect, but there is a semblance of this hybrid warfare. Could I get you to speak to how NATO has approached medical readiness in light of this nature of hybrid warfare?
So what I'd say is that every conflict has got its own character, and it does have its own signature pattern of injuries. So military medical services predictably have to be ready to adapt to the current character. I would just emphasize that the nature of warfare is actually quite constant, and that's the use of lethal means to achieve political objectives, just as the nature of military medicine is constant, which is to save life and reduce suffering of those injured and sick service personnel. So it's the character of fighting wars that changes, as in Ukraine, where the use of drones signifies a new method of war. And it's the character of military medicine that changes, how we innovate to improve outcomes from the novel combat related injuries or find new ways of solving old problems, such as stopping the bleeding. And we do this collectively in NATO. We share learning and understanding, and we seek to develop common solutions through our research networks, and we lever the intellectual horsepower from across the alliance. And two of the networks that are important are the COMEDS Futures Advisory Board, or CFAB, which has a specific interest in pre-hospital care and emergency medicine research initiatives, and the Human Factors in Medicine panel, which is part of NATO's Science and Technology Organization. And that provides a strategic bridge to connect the military and civilian scientific worlds across the alliance. Now, you asked specifically about cyber threats and hybrid warfare. And while military medicine does not lead on cybersecurity, it's certainly got a voice. And examples of the threats relate to our field hospitals, where they would range from the denial of digital communication by electronic countermeasures through to the impact of having a visible digital signature that might identify a field hospital to an enemy for targeting. And what we're all aware of today, of course, is whether we're military or civilian, is how cyber warfare might disrupt our critical national infrastructure at home, and specifically our health system networks, without the need to fire a single shot or launch a single missile. And in this respect of hybrid warfare or sub-threshold acts of war, everyone within our health system has got a role to play in digital security to prevent any vulnerabilities being exploited.
What are the lessons learned, Tim, from some of the recent conflicts? I think you've already mentioned Ukraine and Ukraine was differentiated from Iraq and Afghanistan, where we had the prevailing control of the skies and indeed the prevailing maybe indeed artillery and firepower. More peer-on-peer conflict, as you said, is by architecture and design is very different. Could I get you to speak to some of the lessons learned from certainly from Ukraine as a case study that has indeed shaped NATO's medical strategy?
Yeah, so what we proved in Iraq and Afghanistan is that it's possible to achieve extraordinary and unprecedented outcomes from serious injury when the conditions allow advanced intervention to start immediately after injury, and when there's rapid evacuation to initial surgery and then onward evacuation to definitive care. But the uncomfortable truth from the experience in Ukraine is that these extraordinary outcomes will not be achievable in high intensity conflict. And our case fatality rate will substantially rise when pre hospital treatment and evacuation are contested, when we're in what we call a non permissive environment. Now, we do know what our risks are in detail. And we've arranged the principal risks into 5 main domains, and we've presented these as a medical manifesto for change to the heads of state and government, and they endorsed the manifesto at the Washington summit last year. And importantly, we've got the action plan to treat the risks, and we are now actively addressing them. Of course, the key question you're going to say is, what are these 5 domains? And without going into too much detail, because that changes the classification of what we're talking about, but I can tell you the sort of the headlines and the main risk areas that we are managing are the clinical workforce, medical evacuation at scale, medical logistics, mass casualty planning, and regulatory constraints.
All of those fundamentally important, actually, for very different reasons, actually, Tim. Could you maybe speak to, so you've already spoken to shared lessons learned from allied nations, just creating a new unified approach. Could I get you to speak to some of those insights, the declassified insights that nations do share to unify an approach to combat medicine and indeed pre-hospital critical care on the battleground?
The lessons process is clearly central to any organization that wants to demonstrate that it's continuously improving and improving, in our sense, the clinical outcomes. So we need to collect and analyze lessons and use them to change our policies, equipment, and training. And the agency in NATO that does that is the Military Medical Center of Excellence in Budapest. That's our principal coordinating authority. And MilMed COE has completed an extraordinary effort to learn from Ukraine's experience and to make recommendations where the lesson is transferable into the NATO environment. And importantly also is that we are now publicly sharing these lessons where appropriate. So you will find them increasingly in the military medical literature. And this includes my own personal analysis of what I've called a dirty dozen key lessons from the Russia-Ukraine war, which I've drawn up and have serially refined from the outset of the conflict. And you'll find the detail of those in an article in BMJ Military Health Journal. But just as an example, an opener lesson is that medical indicators and warning are predictive of war. So we could see before the conflict started that hospitals were moving to the border in Belarus and in Russia and in Crimea, and that there were blood drives going on in civilian universities to obviously build up the stocks for warfighting. And we also saw large animal modeling exercises going on in the forward Russian hospitals with reach back to Roll 4 in St. Petersburg. And all of this was on open source material. So it was on social media. You didn't have to look very hard to actually find it. But putting all that together, as Napoleon said, if you see your doctors moving to the front, then you know that the enemy is preparing to fight, because they are accepting the potential to take casualties. So we have to take military indicators and warnings seriously, and commanders can use that as a genuine warning for war.
Let's talk about mass casualty incidents for a minute, because it's prudent to understand how NATO's medical systems are equipped to manage mass casualty incidents at high intensity and high frequency. We've seen some fantastic innovation and iterations in the 10-second triage and a major incident tool. Just to simplify triage and decision making at the front lines, and then start to categorize and move priority one patients through to fundamentally to intervention quicker and damage control surgery quicker. Could I get you to speak to NATO's medical systems to manage mass casualty incidents? And indeed, you said they've been pressure tested already. What are some of the key learnings that have come out of those?
Yeah, so it builds on what I've been saying already, but we have been forced to rethink our approach to mass casualties in war and actually to create a new set of principles. And you might say, well, why do we need a new set of principles? Because in peace and low intensity conflict, our response has focused on a burst of casualties at a point in time. So the plane crash, the train crash, the terrorist bomb, or even the earthquake or tsunami. And the principles for managing those bursts of casualties will be very familiar to the audience because they are the principles of MIMS, Major Incident Medical Management and Support, and they've stood as in great stead for the last 30 years. But in war, there's a need to manage an enduring high volume of patients that may endure for months or years. So there's a new paradigm that's been published by Colonel Simon Hall and colleagues as the 8Ds. And this is absolutely shaping our new strategy within NATO for enduring mass casualties. Now, the 8Ds break down to be distribution of casualties, delegation of treatment to the lowest level of capable provider, decompression of field medical treatment facilities, so field hospitals, with an effective evacuation process so that we can clear the back door and allow the field hospital to function as a pumping heart, rapidly filling, rapidly emptying, and then rapidly filling again. Faster delivery through greater efficiency, better delivery through exploiting technology and process innovation advances, delay in treatment where it's possible and acceptable, a dynamic level of care where we have a sliding scale of care packages. And when there aren't many patients, we can deliver a large number of packages for an individual patient. But when there are a lot of casualties, then the number of care packages that we can deliver for individual patients is going to be reduced. So it's dependent on resource availability. And then ultimately is the eighth D, de-escalation, with a shift in the threshold of care delivered. So, for example, instead of a minor wound being managed by a medic or a nurse, then it has to be managed by self-care. So the 8Ds, and they are also published in open source in BMJ Military Health.
No, that's fantastic. And we'll put links in the show notes to those, actually, Tim. That's fantastic. Could I pivot slightly and just look at the role and innovation of telemedicine, robotics, and AI? Could I get you to speak to sort of how NATO has really kind of adopted these technologies to facilitate and or prepare for medical provision? Could I get you to speak to whether there's more investment needed or whether NATO really has fundamentally adopted these technologies?
So let me just consider innovation in total before looking at some specific examples, because our ability to innovate and to be early adopters of new technology and to translate any military medical benefits that we can demonstrate for wider civilian advantage, I think absolutely characterizes our approach to combat casualty care in the last 25 years. And long may that mindset continue. And I've also written about the precepts that underpin effective innovation and change at pace in crisis. And I published that in a BMJ Leader article. And that article provided a framework that I designed as a result of our trauma innovation for civilian colleagues during COVID. So I think that's absolutely worth a look for the common precepts for innovating at pace during crisis. But you asked specifically about telemedicine, and in my experience, the best telemedicine in a deployed setting is the telephone. But of course, there's added value through video consultation, which is coupled with live stream of vital signs. And we do have some examples in our UK defence setting of very effective real-time support to remote and austere locations, to individual medics on the back of a vehicle, providing care over a large distance during road evacuation. So these methods do work, but of course it is dependent on the reliability of the communication link. And then artificial intelligence as a strategic innovation is already impacting substantially on medicine. And how we can exploit this, for example, in our triage of the injured, or our triage of finite resources, or differential diagnosis and decision making, and indeed in intelligent anticipation for timely resupply, because you're at the end of a 5,000-mile supply chain, you've got to think early about resupply, are all potential user cases that are yet to be fully matured. So just as the Prime Minister was saying earlier in the week, the importance of us being leaders in AI, how we exploit AI in that military medical community will be a potentially very valuable asset to us.
I absolutely agree with you, actually. And, looking at the aggregation of AI's capability to understand where the provision needs to be, even like you said, in and around supply chains, which has been a rate limiting step, I think, in the current conflict. So it's actually prudent to adopt this technology to understand early those rate limiting steps. One of the significant challenges that I think any multinational approach faces is interoperability and nonetheless, actually, in medical training and equipment across its diverse member nations. Could I get you to speak to how NATO has optimized interoperability?
So interoperability is absolutely at the heart of the NATO alliance. It's its foundation, and it's essential for medical effectiveness, because wherever we go in the future, we're very unlikely to go alone, and we will be working within a multinational partnership. We have to work together. And in NATO, interoperability is achieved principally through standardization, through the NATO Standardization Organization, and through generating consensus within what we call STANAGs, or standardized agreements. And these agreements are binding, but they do need full consensus of every nation, so they can take quite a while to achieve. But we can also create what are known as STANRECs, or standardized recommendations. And these are non-binding, and they don't require every NATO nation to agree to them. So it may be a sort of a coalition of the willing who wants to press on with a recommendation, because they are often much quicker to generate, while paradoxically allowing a lot more technical detail because they're not binding. And in a multinational field hospital, we will commonly have a framework nation, and all of the participating nations have to follow the framework nation's guidelines and governance and use their equipment and drugs. So in this case, interoperability is achieved when we all train together against a single nation's guidelines and equipment. And of course, ideally, we do that before deployment, but it's still been possible sort of to do it while in contact, as it were. But it's a very well tried and tested model within a field hospital setting. And indeed, I would say that military medicine leads the way in working in that interoperable way. So I led a multinational field hospital in Afghanistan in 2009, where half the staff were Danish and a quarter were American, with the final quarter being British. I actually learned Danish in order to be as effective as possible in that setting. But the hospital remained under British governance. It used British guidelines, it used British equipment, and it used British drugs. So for framework nation, in a multinational setting, is the way we can still get interoperability and interchangeability of individual clinicians or teams from other nations to work with us.
So you said something really interesting, Tim, earlier about ultimately some of the most beneficial treatment is around self-care and training the frontline soldiers to really upskill and appreciate some of these life-saving techniques. I understand that the Americans, certainly the TCCC, have moved to March instead of CABC as their sort of fundamental algorithm that they're now prescribed to. But could I get you to speak to really some of the steps being taken to prepare medics and pre-hospital teams for unique challenges of modern warfare.
So I think this does link with the answers already in terms of learning lessons at both the national and international levels and being able to translate those lessons rapidly into guidelines, training, and equipment. And I'll absolutely be the first to recognize that this is much easier when you are in conflict than in peace, because in conflict, the sort of artificial barriers to rapid change and adaptation to the changing environment, those barriers come down. And in the conflicts this century in Iraq and Afghanistan, we held a weekly clinical governance meeting. So this weekly cycle was possible to implement changes to training and guidelines. So it's just a matter of days to make these changes, and it led to a strategic drift in the outcomes that we were able to deliver in a field setting versus in a UK teaching hospital. And most importantly, it was driven by the scrutiny of every single seriously injured casualty and every single operational death. And we were doing that in near real time. Now, I would say that we can do this again in the next conflict. We might think that we've forgotten how, but we ensure that all of these processes were codified in our journals and explained so that the processes can be replicated on future operations. So if we are going to change rapidly in the future, whether it's preparing our medics and pre-hospital teams most effectively for the current threats, or whether it's the teams that are working in a hospital, then data is king, and collecting near real-time data and analyzing it and changing on the hoof is how we will progressively improve our outcomes in the next conflict.
Can we pivot slightly, Tim, and look at civilian civ-mil collaboration? And just really, I'd like to get your thoughts on how NATO balances military medical readiness with indeed the need to support civilian populations in or around conflict zones.
Yeah, when we plan a military operation, we do estimate the likely daily casualties and we design our system to cope with this, both our pre-hospital and our hospital system. However, unless we're going on a humanitarian operation or a non-combatant evacuation operation, a NEO, then the estimation doesn't usually include civilians, even though on every operation that I've deployed in the last 40 years, we've always treated local civilians. So while there may be an assumption by commanders that treating civilians isn't part of the military mission, once civilians do enter the evacuation chain, then they are going to get treated until they can be safely handed off to a competent civilian healthcare provider. And in war, as we can see in Ukraine, there will inevitably be military patients who find their way into far forward civilian facilities and vice versa. And to address civilian military collaboration in war at the strategic level, I facilitated in the last 18 months a series of meetings of the national civilian healthcare leaders of NATO nations, where they could meet their military surgeon general counterparts. And we could ensure that it was understood that there's a dependence in all home nations on civilian hospitals to treat our military patients when they're repatriated. And in some countries, such as the UK, this is absolute because we have no independent military hospitals anymore. And in other countries, it's relative, dependent on the number of military hospitals that they retain. So perhaps your question actually raises the important challenge that the main concern in war is not how military facilities can support the civilian population, but how civilian facilities can create the capacity to treat large numbers of military injured, and certainly at least in the period that it's going to take to rebuild military capacity.
No, indeed, and I think, like say, flipping the narrative is actually quite important from a planning and an implementation perspective to understand the assets on the ground from a civilian perspective, because indeed there are assets. It's availability of surgeons, of paramedics, of otherwise of ED clinicians. Could I get you to speak to the role of civilian healthcare systems in bolstering NATO's readiness for large-scale war. One of the aspects in the UK is that there's a lot of teaching hospitals, and certainly you can speak to this, that actually train and mentor and as analogues. London's Air Ambulance is a famous example in Bart's Health, where they bring certain assets through just to understand the pathology, understand the injury patterns of penetrating disease. So this kind of mentorship, bilateral mentorship of adjacent systems and services in the civilian world. Could I get you to speak to really how civilian healthcare systems bolster NATO's readiness for large-scale war?
So if we take UK as an example, the National Health Service will have to absorb the military patients when they return to the UK. And the process that we have is called RAMP, Reception Arrangements for Military Patients. And over the last 20 years, that has been successfully delivered effectively by a single hospital. Within Birmingham, the Royal Centre for Defence Medicine, which is embedded within the Queen Elizabeth Hospital, Birmingham, with occasional need just to go a little bit wider. But that will not work in large-scale combat operations, and that individual hospital might take the first burst of casualties, but then we would have to do what we planned to do in Gulf War One, but never actually had to enact to any large degree, which was to rotate around the country the receiving city, and the aircraft would fly into that particular airhead and offload and distribute to the hospitals in that particular city. However, we should also remember that there will be a limited number of strategic aircraft, and dependent on the way that we move patients across the European continent, including by train and potentially from the high north by ship, then they won't all be arriving at airheads. They might arrive at sea points of disembarkation. They could even come through the Channel Tunnel to St Pancras on Eurostar, and we offload patients from train and then redistribute by train to other parts of the country, which to some extent says we're going to have to be prepared to use all of our national assets, including across the devolved administrations, to absorb the number of injured that may come back. So how do we prepare those civilian hospitals? Well, we're already well ahead, because in 2017, EPRR, Emergency Preparedness, Response and Resilience, asked the Royal Centre for Defence Medicine to generate the major incident and mass casualty guidelines for the NHS. And they are derived from the clinical guidelines for operations, which I first wrote in 2003 while sitting in the desert in Kuwait immediately before the second Gulf War, and now remain the guidelines for all emergencies across all of the services. For the UK, but we turned those in 2017 into guidelines for dealing with blast and ballistic trauma, because the threat at that time was terrorism. But of course, whether it's an injury inflicted by a terrorist or an injury inflicted by an enemy during war, there's similar patterns of injury. So every single hospital has got those NHS guidelines already. I did do a straw poll at the London Trauma Conference in December, just to see how many people had read them, and very few people were even aware of them. So a little bit disappointing that the answer is already out there in the acute trusts, how to prepare. They just don't know that they've been given the guidelines.
So as we're coming to land actually on the conversation, Tim, just a few more questions. One would be quite a tricky question actually, around ethical considerations and indeed humanitarian considerations around, as you said before, the heterogeneous casualties that war brings up, fosters the ethical challenges, really providing care to both allies and adversaries. How does NATO address that?
Yeah, well, I think this is to some degree a false dilemma, because once patients are in the military medical system, then they're going to get treated on clinical need. And whether you're friendly forces or enemy forces, you are going to get life-saving treatment, the same life-saving treatment within a field hospital. However, if you're enemy forces, then you're not going to enter the same onward evacuation chain that would repatriate our own injured to home. However, we can't expect the same behavior from the medical services of our enemy, and in particular from Russia, even though it's a stipulation of the Geneva Convention. And there's plenty of examples, the audience will be well familiar with this, where Russia has shown flagrant abuse for the principles and protective emblems of the Geneva Convention when it's deliberately targeted medical facilities or medical transport and medical personnel, down to individual stretcher bearers being targeted by grenades or bomblets from drones.
So, Tim, could I just finally get your thoughts on the psychological resilience of NATO medical teams and indeed how we can better support their mental health in high stress environments?
Yes, of course. Now, I've worked in very intense environments, whether this is crisis, disaster, conflict, or war. And in these environments, undeniably, there's the potential for moral injury. But we do prepare ourselves for these environments. We anticipate the challenges. We educate our providers, which includes conferences on medical ethics, and we exercise hard because when the difficult discussions have happened in a training setting, then it becomes much easier to deal with the situation when you're standing over the patient. But it's not possible to anticipate every situation, and you do need other coping mechanisms. Sometimes it might be appropriate just to lower your horizon, accept the situation, accept your own mortality, and focus on those few things that you can control. You become reliant on the people around you for mutual support, and you find you make unusually strong bonds with those who share those same critical experiences. But for me, perhaps the greatest challenge is when you're in a leadership role. And specifically, as medical director of a field hospital, which I've done on 6 occasions, everyone is looking to you for support. But who is there to support you? And the answer is there isn't anybody. So my means of dealing with serial traumatic and morally injurious experiences has been to write contemporary war poetry. I've done this for over 30 years. It's now been published. It was launched last year at the Edinburgh Fringe, and the royalties go to the Poppy Factory charity, of which I'm a trustee. The book is called Frontlines and Lifelines, and if it doesn't make you both laugh and cry, you may need to check your pulse.
Listen, that's fantastic, Tim. I think what we'll do is we'll put that in the show notes as well because it's fantastic just to, like you say, get your recollections. And true to say, putting emotions, thoughts, and feelings down on paper, there is some transferal of emotion and hopefully some perspective gaining from that experience. And I'll certainly be reading that. Tim,
People certainly have said they've cried.
yeah, indeed. No, indeed. I think it's profound actually. And you've had such a unique perspective really on peacetime and wartime. So I think it'd be profound actually. Tim, what we'll do is we'll put links in the show notes to all the documents you've mentioned in the episode. I think it'd be really useful for people to go back through and read some of those documents, and we'll link them in the show notes. It just leaves me to say thank you for the past 45 minutes. It's been fantastic to get your perspectives and also your steer on preparedness from a multinational perspective. So thank you so much.
Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.